Hello everyone, welcome back to ProstoHub. Myself Dr. Jolsna, and this is the final session of our topic practical exam preparation with case history discussion. So in the past two sessions we have discussed the general things to take care while preparing for your practical exam, and also we have discussed till the intra-oral examination in the case history discussion. And coming to the next section, that is the radiographic examination. But before getting into detail, I request everyone to please do like and share my videos if you are finding them useful. And if you are new to this channel ProstoHub, please subscribe ProstoHub and support me. And if you have any queries, any topics that needs to be discussed, any suggestions or feedbacks, you can comment below this video or you can mail me at this mail ID. So I'm getting a lot of topic suggestions and I shall be trying to do it one by one in their suggested orders. So please stay tuned. So the radiographic investigations for the complete danger fabrication includes the panoramic radiograph and the lateral ceph. So the panoramic radiograph are usually used to find out any pathologies like retained root fragments, unerupted teeth, cysts, tumors, TMJ disorders, and also to check the maxillary sinus for any inflammation, cyst, polyp or tumors, and also the amount of ridge resorption and the quantity and quality of the bone can be assessed. Whereas lateral ceph is used to find out the skeletal relationships of the maxilla and mandible, that is angles class 1, class 2, class 3, and also the facial profile. Now, how do you estimate the amount of ridge resorption using a panoramic radiograph? And that is done by Wickhall and Swoop technique, which is an important viva question. So here, the distance between the lower edge of the mental foramen, so this is the lower edge of mental foramen, to that of inferior border of the mandible. So this is the distance is x, and that is multiplied by 3 to get the original alveolar ridge crest height. That is, original bone height will be 3 times the distance from inferior border of the mandible to the lower edge of mental foramen. So this is the Wickhall and Swoop technique for estimating residual ridge resorption. And based on this technique, the residual ridge resorption was classified by Wickhall and Swoop as class 1, class 2, class 3. Class 1 where there is mild resorption, that is up to 1/3 of the original vertical height is lost. Class 2, a moderate resorption where there is a loss of 1/3 to 2/3 of the vertical height, and severe where 2/3 or more of the mandibular height is lost. So this is the Wickhall and Swoop classification of residual ridge resorption. Now the next section is diagnosis, where we are going to discuss the prosthodontic diagnostic index or the PDI for complete edentulosum. So the American College of Prosthodontics developed the official classification system for complete edentulosum in the year 1999, and this classification was based on 4 diagnostic criteria, that is the mandibular bone height, the maxillary residual ridge morphology, the maxillomandibular relationship, and the muscle attachments. So based on these diagnostic criteria, the patients were classified into 4 classes. Class 1, ideal or minimally compromised. Class 2 is moderately compromised. Class 3, substantially compromised, and class 4, severely compromised. So let us see the feature of each of these classes. So this is the prosthodontic diagnostic index classification system checklist. So you can see here the first 4 criteria, the bone height, the maxillary ridge morphology, muscle attachment, and maxillomandibular relationship. And based on this, you have to tick mark which class it falls into. So the mandibular bone height, it is based on 4 types, that is 21 mm or greater, 16 to 20, 11 to 15 mm, and 10 mm or less. So this mandibular bone height is measured at the area of least vertical bone height in an OPG. Now coming to the maxillary ridge morphology, that is also classified into type 4, that is type A, B, C, and D, based on their resistance to vertical and horizontal forces and the presence of a good hamellar notch and presence of tori and so on. Then the muscle attachment, again the mandibular muscle attachment is classified into 5 classes, that is type A, B, C, D, and E, based on adequate attached mucosa and whether there is presence or absence of anterior buccal and labial vestibular mucosa. Then the maxillomandibular relationship, that you know, class 1, class 2 and class 3. Then the conditions requiring pre-prosthetic surgery, if any, should be noted down, and also if there is limited interart space, so in case where there is surgical correction is needed, you have to note that. Then based on the tongue anatomy, you have to mark it whether it is a large or a hyperactive tongue with retracted position, and any modifiers, that is if there is any oral manifestation of any systemic disease, any psychological manifestation or TMD symptoms, all these you have to note in this PDI, that is Prosthodontic Diagnostic Index Classification System. Now let us see the features of each classification. So we know that class 1, that is ideal or minimally compromised, where the bone height is type 1, that is 21 mm or greater. So this is measured at the area of least vertical bone height in an OPG. So here, so that is 21 mm or greater bone height. The residual ridge type is type A, that is the vestibular depth, palate and tuberosity are resistant to horizontal and vertical movement of the denture base. And then a well-defined hamular notch is also present. The muscle attachment, it is type A or type B, that is attached to mucosal base at all areas or all areas except the labial vestibule. So the muscle attachment location is connected to denture base stability and retention. And then the maxillomandibular relationship, that is class 1 relation, that is ideal ridge relationship. Coming to class 2, moderately compromised patients. So here the bone height is type 2, that is 16 to 20 millimeter, that is measured at the area of least vertical bone height. And then the residual ridge type, that is a maxillary type, residual ridge type is type B. There is a posterior vestibular loss and hamular notch and tuberosity are not well defined. And the muscle attachment is type A or B, that is they exert limited compromise on denture base stability and retention, and the maxillomandibular relation is again class 1 relation. And also there is minor psychosocial considerations, mild systemic disease with oral manifestations. So these are the features of class 2, that is moderately compromised. Next is class 3, that is substantially compromised. So the criteria are bone height is of type 3, that is 11 to 15 millimeter, and then the residual ridge type is C, that is with anterior vestibule loss and also hypoplastic mobile anterior ridge and a flat palatal vault. The muscle attachment is type C, that is loss of anterior labial and lingual vestibules. So here the muscle attachment exert moderate compromise on the denture base stability and retention, and then their maxillomandibular relation can be class 1, 2 and or 3 relation, and the other features are decreased interarch distance, or there may be conditions requiring pre-prosthetic surgery, a hyperactive gag reflex or TMD symptoms. So these features, if present, the patient can be included in class 3, that is substantially compromised. Finally, class 4, that is severely compromised, where the bone height is type 4, that is 10 mm or less than that, and the residual ridge type is type D, where there is no resistance to the movement of denture base and only has a prominent anterior nasal spine, and the presence of tori or exostosis. And here the muscle attachment is type D, that is only posterior lingual vestibule is the one that remains. There is no attached mucosa. Even the cheek or lip can move the tongue. And then maxillomandibular relation can be class 1, 2 or 3, and there can be major conditions that require pre-prosthetic surgery, for example ridge augmentation, or there can be severe oral manifestations of any systemic disease or psychosocial conditions that require professional intervention. So these are the features of class 4, that is severely compromised. So this is about the Prosthodontic Diagnostic Index Classification System, which was proposed by American College of Prosthodontists. Coming to the next step, that is treatment planning, and that includes elimination of infection. So some infections like necrotic ulcers, periodontally weak teeth, non-vital teeth, etc. should be removed, and elimination of pathology, that is pathological cyst, tumors of jaw should be treated or removed, and then nutritional counseling should be done, and then the prosthodontic care. Then in the treatment plan you have to mention whether the tissue conditioning is required or finger massage is required based on the type of the treatment material and frequency of appointments. Then whether pre-prosthetic surgery is required, and then the impression procedure and the material used for primary as well as final, and then the jaw relation and articulator, the face board transfer, the articulator and its control settings, the tooth selection, the shade, mold, material and number, and then the denture base material. So here you can expect questions on your articulator model, that is which Hanno model series you are using, the articulator parts, their significance, Hanno's formula, classification of articulators, and the different type of tracers and phase pore transfer, two types, that's a direct and indirect phase pore transfer, what's the difference. All these questions you can expect from this section. Next is the prognosis, which should indicate the number of years patient can successfully use the prosthesis with satisfaction. So this is depending on certain factors, and these factors are, first one, the present mandibular bone height. After giving allowance for the inevitable residual ridge resorption that may occur, the mandibular bone height should be sufficient after 5 years to support the prosthesis and withstand masticatory forces. Then residual ridge status. So healthy ridges withstand masticatory forces more efficiently than flabby tissues. So if there is flabby tissues, it can reduce the time of efficient denture service. Then mouth opening, the degree of mouth opening. So in cases of like a substantially compromised patient, that is ACP class 3, there is limited mouth opening. So the patient's masticatory efficiency may be reduced even though a good denture is made. Then the nutritional status of the patient. So as the complete edentulous individual cannot chew well, there is lack of adequate nutrition, and it can affect the rate of formation of new cells and new bone formation, which will affect the dynamics of bone remodeling. And finally, the medical condition of patient. So in case of diabetic patient, there may be increased rate of residual ridge resorption, or it may affect the healing of tissues or decreased stress tolerance. Similarly, hypertensive patients can have xerostomia and also reduced stress tolerance, etc. So all these will reduce the expected duration of trouble-free service of the prosthesis. So based on these factors, the prognosis can be classified as good, fair or poor. And finally, your case sheet should include the SOAP summary. So SOAP stands for subjective, objective, assessment and plan. So subjective is what the patient tells you, that is the patient's chief complaint, history of present illness. It should include the past medical history, dental history, patient expectation, etc. So for example, you can write patient complaints of missing teeth, states that the teeth were extracted as they were mobile or were decayed. Past medical history is non-contributory. However, patient admits to smoking and the frequency. The past dental history, patient's past experience with dentist, the treatment received including restoration and prosthesis if any. Then comes objective, that is what you see on extraoral examination. That is the facial form, the symmetry, the profile, muscle tone, TMJ, lip and intraoral examination including radiographic findings if any. So for example, the extraoral examination includes so and so. The intraoral exam reveals displaceable fibrous tissue in the maxillary anterior region, knife edge mandibular ridge, class 3 palate throat form, pigmentation in the buccal mucosa, white patches on the buccal mucosa or inflamed papilla. Radiographic examination shows a mandibular bone height of less than 12 mm in the premolar region or an impacted third molar, so on. So next is assessment. So here you have to mention the problem list or the diagnosis. So that is based on our ACP classification criteria. So we have discussed in detail in the previous slides. And here you have to mention which class the patient falls into. Finally, the plan that includes the treatment option, the materials used, stages of fabrication and financial consideration. So here you can mention the type of the treatment plan that is finalized after discussing with patient, whether he needs a removable complete denture or a removable implant retain or fixed implant supported prosthesis. And then the sequence of treatment planning is also mentioned. So for example, the primary impression with the material, the final impression, then the phase pore transfer that is used with the semi-adjustable articulator, the type of teeth that is selected, type of occlusal scheme that is planned. So all these you have to include in your SOAP summary. So here comes the end of our session. So I wish good luck to all of you for your practical exams, especially those who are going to attend exams within 1 or 2 months. And one more thing I would like to add is that you might have unpleasant experiences from the external examiners. I'm not saying that all externals are like that, but some of them might check your threshold level of patience. You might feel insulted or humiliated in front of others, but just bear with it. Don't take it into your head. It might affect your further performances. just hear it and leave it. It's just a matter of 2-3 days. And at the end of the exam day, I'm sure that those externals will shower their blessings on you. So prepare well, work hard, and party harder after the exams. These are my references, and among these I would like to recommend this textbook, A Primer on Complete Denture Prosthodontics by Chandrasekharan Nair sir, chapter 2 on patient evaluation. You can refer for your case history discussion. It is very well explained and it will be useful for you. So thank you all for watching this session. Please do like and share my videos if you're finding them useful, and please do subscribe my channel and support me. If you have any queries or suggestions or any feedbacks or any topic that needs to be discussed, do comment below this video, or you can mail me at this mail ID. So it's bye from Prosto Hub until our next session.